Just let that sink in for a moment. People would give up more than a decade of their life to be free from this condition. That tells you everything about the profound, life-altering impact of irritable bowel syndrome, and it's exactly why we need to understand the science behind it.
Welcome to The Explainer. Today, we're going to decode the real science of irritable bowel syndrome. We're going to move past all the myths and confusion to see what the latest clinical evidence actually tells us about how it's diagnosed and, more importantly, how it's treated.
So, first things first, what exactly is irritable bowel syndrome? Let's get a clear definition. Okay, so according to the official guidelines, these are called the Rome 4 criteria. IBS boils down to this. You've got recurring abdominal pain, at least once a week, and that pain is linked to, going to the bathroom. And along with that pain, you see changes in how often you go, or what your stool looks like. It's really that combination, the pain plus the changed bowel habits, that defines the condition. And make no mistake, this is not some rare, obscure condition, not at all. In a country like the United States, it affects nearly 5% of the entire population. We're talking millions of people who are dealing with these disruptive symptoms day in and day out.
Now, a huge part of the IBS story isn't just knowing what it is. It's the journey of actually getting the right diagnosis. And that journey has changed big time.
This right here, this highlights a massive, revolutionary shift in how doctors think about IBS. For years, it was what's called a diagnosis of exclusion. That meant doctors would run endless, expensive, and stressful tests just to rule everything else out. It could take years, leaving patients in this awful limbo. But the new way, it's called a positive diagnostic strategy. And it means a doctor can confidently diagnose IBS just based on your specific symptoms, using those Rome criteria, without needing a whole battery of invasive tests. It's a game changer. And the impact of this new strategy is just huge. It's not just faster and way less stressful for patients, it's also dramatically cheaper. You can see it right here. This new approach leads to a nearly 40% drop in annual healthcare costs. We're talking about going from over $5,000 a year down to just over $3,000. That's a real difference.
But hold on, this doesn't mean we just ignore potential red flags. Absolutely not. Clinicians are always on the lookout for what they call alarm features. These are things like losing weight without trying to, seeing blood in the stool, or having a family history of something more serious like inflammatory bowel disease or colon cancer. If any of these show up, then yes, more testing is absolutely the right call.
And when that extra testing is needed to rule out conditions that can mimic IBS, it's not a wild goose chase. It's a smart, targeted pathway. It's really just two simple steps. First, a blood test to make sure it's not celiac disease, and second, some stool and blood markers to rule out inflammatory bowel disease, or IBD. That's it. It's efficient, it's evidence-based, and it gets you answers without unnecessary procedures.
Okay, so once that positive diagnosis is in place, the whole focus shifts. Now it's all about tailoring a treatment strategy that works for you. And here's why that tailoring is so important. IBS isn't just one thing, it's really a spectrum. The main types are defined by your bowel habits are mostly like, so there's IBS with constipation, which we call IBS-C, and IBS with diarrhea, or IBS-D. Knowing which subtype you have is the absolute first step toward managing it effectively. So how did doctors figure out that subtype? Well, often with this simple but incredibly useful tool. It's called the Bristol Stool Form Scale. And I know it might look a little strange, but by figuring out where a patient's stool most often lands on this chart, a clinician can classify their IBS and pick the best therapy. It's a perfect example of a really low-tech tool that has a huge impact. So with that personalized diagnosis in hand, we can finally open up the treatment toolkit and see what's inside. The first, and for many people, the most powerful strategy in that toolkit is all about diet. It just makes sense, right? What you eat has a direct, immediate impact on your gut. Now, one of the most well-researched dietary plans is the low FODMAP diet. But here's the thing so many people get wrong. This is not a forever diet. You're not supposed to stay on it for life. It's a 3-phase diagnostic tool, and it's best done with a dietitian. You eliminate these fermentable carbs, then you systematically reintroduce them, and finally, you personalize your diet based on what you learned. The whole point is to figure out your specific food triggers. All right, next up in the toolkit, targeted medications. And these have come such a long way from the old days of just, managing symptoms. These are much smarter. And this is where that subtyping we talked about becomes absolutely crucial. The treatments are super specific.
For example, if you have IBS-C, a doctor might use a drug like lubiprostone, which basically increases fluid in your intestine to help things move along. But for IBS-D, they might use something totally different, like rifaximin, which is this unique antibiotic that only works inside your gut to target the microbiome. The therapy is matched directly to the problem.
Our third strategy is, well, it's maybe the most fascinating of all. We're talking about therapies that target the brain-gut axis. Think of it as this constant two-way communication superhighway that runs between your brain and your entire digestive system.
Now, I know the brain-gut axis can sound kind of abstract, but this image here makes it crystal clear. It shows the difference between a normal bowel movement and something called dyssynergic defecation. See how on the dyssynergic side, the signals from the brain are all mixed up? The muscles that are supposed to relax are actually contracting. It's a perfect illustration of how a communication breakdown can cause a very real, very physical problem.
So if the problem is miscommunication, the solution is to fix the communication. And we have therapies specifically designed to do that. These include things like neuromodulators, which can help dial down pain signals, gut-directed psychotherapies like CBT, and biofeedback, which is amazing for actually helping you retrain those misfiring muscle responses.
So after all that, where does this leave us? Let's take a quick look at what the future of IBS care really looks like.
What is the path forward for managing this incredibly complex and personal condition?
Here's the main takeaway. The bottom line, effective IBS care is a partnership. It has to be personalized to your specific subtype and your triggers. It has to be evidence-based, using proven strategies from all parts of that toolkit. But most of all, it's a collaboration between you and your healthcare provider. There is a clear path to feeling better.
And that leaves us with one final, very exciting question. As our understanding of the trillions of tiny microbes living in our gut gets deeper and deeper, could a real cure for IBS be found right there? Not just managing symptoms, but truly rebalancing our internal ecosystem? The science is moving incredibly fast. And you know what? The future is looking very, very hopeful.